Welcome everyone to the Canadian Nurses Association webinar series, Progress in Practice. Today's webinar is Malnutrition in Hospitalized Patients, a serious problem calling for interdisciplinary engagement. This session is being recorded for those who are unable to participate today. My name is Josette Roussel and I'll be hosting this webinar. I'm currently working at the Canadian Nurses Association as the program lead in nursing practice and policy. At the end of the presentation, we will host a Q&A session with the speaker, and we will answer as many questions as time allows. And now a little bit about our presenter, Bridget Davidson. Bridget Davidson worked in the hospital sector as a clinician, dietitian, manager, and professional practice leader, consultant for the past 34 years. Since early 2000, she's been working with the Canadian Malnutrition Task Force, initially as the National Project Coordinator, working with the study coordinator from 18 hospitals in Canada to implement the Nutrition Care and Canadian Hospital Study Protocol. Now, as the Director, she works with the Canadian Malnutrition Task Force Advisory Committee, translating the research findings for everyday clinical practice. A major focus has been training and coaching hospitals implementing the integrated nutrition pathway for acute care, an algorithm of care that guides health professionals in preventing, detecting, and treating those with malnutrition. Now, let's hear from Bridget. Over to you, Bridget.
Thank you very much, Josette. I just want to make one clarification. I started with the Canadian Malnutrition Task Force in 2010. So that's as long as the group has been organized. So thank you for that introduction. And if you could progress to the next slide, please. So who is the Canadian Malnutrition Task Force? We are a standing committee of the Canadian Nutrition Society. It's currently co-chaired by Roseanne Nasser, a research dietitian from Regina, Saskatchewan, and Dr. Leah Gremlich, a gastroenterologist from Edmonton, Alberta. And we are a group of mainly physicians and dietitians, but we are always striving to find nurses to sit on this task force. Our vision is to advance nutrition care through research, education, and interdisciplinary collaboration in Canada. And our 2018-2023 strategic plan has got sort of 4 arms, if you will. It's to support knowledge creation to influence best practice, develop best practices for nutrition care of patients across health sectors, effect a policy and culture change in nutrition care of patients across health sectors, and aggregate current Canadian research and disseminate knowledge of the effect of malnutrition on health. So we did start in hospitals because it was a relatively easy place to start doing our research, but we have expanded and now we're starting to work in primary care, pediatrics, and we're trying to address food in healthcare as with new working groups. Next slide, please. So what we needed to know to begin that research study that Josette mentioned, Nutrition Care in Canadian Hospitals study that began in 2010 and we wrapped it up in 2013. But in order to begin the research, we needed to know what is malnutrition and its prevalence in Canadian hospitals. What is the effect of malnutrition and costs attributed to the problem? What are the gaps in care? And how can we improve the situation? And can we create tools to support change in practice rather than just producing evidence? So that last statement was really important to us because we didn't need just another research paper. We wanted to get involved with knowledge translation activities. So what is malnutrition? Some people don't know really what it means. It's the same as undernutrition. That might be a nicer way of putting it, perhaps. But essentially, it's the inadequate intake of energy, protein, and other nutrient versus the person's requirements for energy, protein, and nutrients. So there is an imbalance. Chronic undernutrition or malnutrition does cause functional changes in body tissues. Example, muscle loss, weakness, immune deficiency, decrease in recovery capacity, and it can create cognitive problems. When people are starved or don't get enough nutrition, they actually respond very quickly to nutrition support. So if we can feed patients orally or enterally or parenterally, they will start to show positive signs and changes in their recovery. And often there are two types of malnutrition: starvation-related malnutrition and malnutrition secondary to chronic disease. So often malnutrition is combined with inflammation or as a result of disease, which can harm the reaction to nutrition treatment. So sometimes that's why patients can be a challenge to feed, because of what is going on with their medical status. So malnutrition or undernutrition does present itself in different forms. You can have malnourished, obese patients. They have excess fat reserves, but they can be deficient in micronutrients, particularly protein. So a long time ago, we used to have what we used to call marasmus and protein calorie malnutrition. And marasmus was total energy deprivation, which is what you see in that picture on the right-hand side, or protein calorie malnutrition, which tended to be, they may have received adequate calories, but they don't, it's not nutritious. So they're, the person may have a distended belly, but they're not well nourished. So there are extremes. The other extreme is that there's a human cost to malnutrition. So when you see the patient here in the right-hand side of the screen, you can see that clearly this person cannot function properly because of malnutrition. So we embarked on our study from 2010 to 2013. We enrolled 1,022 patients from 18 hospitals in 8 provinces. And we were pretty clear that we wanted not just academic teaching hospitals or not just rural small hospitals. So we got a real mixture of hospitals that enrolled in our study. And we began our journey. So the lead paper that came out of this study is, as you see it here, the malnutrition at hospital admission, contributors and effect on length of stay, a prospective cohort study from the CMTF. How do we determine malnutrition? Well, we used what's called subjective global assessment. It's a quick bedside clinical tool that can be used. It's validated in many patient populations. So we use that as our, if you will, gold standard for determining nutritional status. So started off with doing a medical history, which is very brief. You ask about nutrient or food intake. And the reason we put nutrient intake there is because people can have or often require enteral or parenteral nutrition on a regular basis. So it's not just oral food that can sustain them. So we ask about total nutrients. We ask if there's been weight changes. We ask if there has been a change in their intake and their weight. What are their symptoms? Generally, people stop eating or eat less because of GI symptoms, but there could be other symptoms. And we ask if there's been a change, if they've noticed any changes in their ability to mobilize. And we also factor in if their disease or illness has caused them to have a high metabolic requirement, has caused them to have a high metabolic requirement, such as Crohn's or inflammatory, other, particularly Crohn's, not ulcerative colitis, head injury, burns, that kind of thing will affect their requirements because their metabolism is so high. Then the next part of it is a physical exam, and you look at different parts of the anatomy and to determine if they've lost body fat, if they've lost body mass or muscle, and if there's evidence of edema or ascites. The edema and ascites is there to determine if there's been significant fluctuations in weight, thus causing the changes in weight. So what happens after the medical history information is taken and the physical exam is done, then we clarify or determine that the patient is either well nourished, mildly or moderately malnourished, or severely malnourished. And as you can see, there's a rating of an A, B, or C. And We used that in our study. Everyone was trained. The research associates were trained on how to do it. It's not exclusive to dietitians at all. We had physicians, we had diet technicians, nurses who can do SGA as long as they're trained on how to do it. Next slide, please. So what we found out was that of those 1,022 patients, 55% of those patients are well nourished. I should backtrack. These patients were all from medical and surgical wards. We also tracked patients who had a projected length of stay of 48 hours or more. So of those medical and surgical patients, 55% were well nourished, just under 34% were moderately malnourished, and 11% were severely malnourished. And what we did find out is not only are 45% generally malnourished upon admission to hospital, but we also tracked how often, if they were even seen by a dietitian or referred to a dietitian. And it turns out that 75% of the time, the patients that were malnourished were not referred or seen. So what we found, what that meant to us is that we were doing a really poor job in Canada of detecting malnutrition, let alone treating it. And then what we had a health economist do, we collected data to financial information, and we had a health economist analyze the results. And what we found out that was people who are malnourished tend to stay 2 to 3 days longer than well-nourished patients. And that's by taking out all of the confounding variables. So not eating your medicine is costly. Our tagline is food is medicine, medicine heals. So by not eating your medicine, it does cost money, and it's malnutrition is a leading sign of a lengthy and costly hospital stay, because what the economists found out was that just being malnourished alone cost $2,000 more than being a nourished patient. And in 2014, that was $2 billion a year that cost the hospital system. So who is malnourished at admission to hospital? And you can see in the right-hand column, those who are, there's a lot of statistically significant information here, particularly for those who are severely malnourished. So adults who had to rely on adult children to buy their groceries were more likely to be malnourished. The ONS stands for oral nutrition supplements. Those who had been taking oral nutrition supplements such as Ensure or Boost prior to admission were more likely to be severely malnourished. Coming in for a surgical admission, those patients tended to be could be malnourished. Charlson comorbidity higher than 2. So anyone with more than 2 diagnoses was more likely to be malnourished. If you've had more than 2 hospital admissions in 5 years, more likely to be severely malnourished. Infections and number of meds, well, not the number of meds so much, but we also see here that if people who are severely malnourished had a length of stay of 9 days versus the 6 or 7. So that was significant information for us. So this is a little saying that one of my colleagues found. It says, and if feeding is a necessity for all, a pleasure for many, a sin for some, it's also a challenge for others. And we are dealing with people who are malnourished, and eating for whatever reason is a challenge. It could be physical, it could be emotional, it could be a case of access problems to food. So what we wanted to find out while they were in hospital, we actually surveyed, we used a validated patient survey at discharge to ask the patients what they thought of the hospital food, what caused them to not eat. And we wanted to learn more about what goes on during hospital stays. And we ended up getting 887 patients to complete this survey, which is a pretty significant result. So here's one of our many posters that were created for Canadian Malnutrition Week. And this one showed what are the barriers that prevent people from eating. And you can see using this fork that quite a few patients, 69% of the patients, when they miss their food tray, are not given replacement food. 42% did not get the help that they need. 27% are in a poor position to eat. 42% said they were interrupted by staff. 39% said they were disturbed at meals. 35% missed their food because they were MPO for tests. 20% were unable to reach the meal. And 30% said they had difficulty opening packages. So those are organizational barriers, which are, when you look at them, are all preventable. And on the left-hand side of the screen, you see that 30% of the patients did not eat half of the food that was provided. Patients experienced organizational, mealtime, and eating environment barriers. And food quality did influence the food intake. So it's not in this poster, but 25% of the patients did say they didn't like the food. Next slide, please. This is on our website. You can get Dr. Kershi Gigi Boy, who worked at St. Michael's Hospital until he retired and is a member of the Canadian Malnutrition Task Force, wrote this article. And we put it as a one-pager for people to take off the website. And what's highlighted at the very bottom is when somebody's kept MPO, during the first 3 days, the body loses about 10 grams of nitrogen a day, or 62.5 grams of protein, or 169 grams of muscle per day, which is close to half a kilogram of muscle mass, and fat loss is minimal. So when people lose weight while they're in the hospital, what you're seeing here is you're actually accelerating the muscle loss, and the fat loss isn't really what's changing. Losing muscle, as we know, is not healthy, it's dangerous, and it's not good for a patient. So we need to get people off of MPO and get them aware of, keep them on it as minimally as possible, as short as possible, and get them off that so-called diet. It's been a bane of dietitians' existence for a long time, but people get busy, they don't think about it. Okay, next slide, please. Which patients receive a dietitian consult? Well, what we found out was that in our study was that it was not the type of hospital, i.e. academic or community, or it wasn't the presence of a diet technician and having surgery. It did not influence if a dietitian visit occurred. Only one of the 18 hospitals had a standardized screening program and was not fully linked to dietitian involvement. So nutrition risk screening is the first simple step in trying to detect patients who are malnourished or who are at risk of malnutrition. So even though that one hospital had a screening program, it wasn't successful because in that the nurses or whoever was doing the screening was not making appropriate referrals to dietitians. So again, the patients were being missed. So of the 1,022 patients that were enrolled in the study, 45% of the patients only 23% were referred to the dietitians. And of those 23%, 45% were well nourished. And 36% of the patients were SGA-B, which is mildly moderately malnourished, and 19% were SGA-C. So 75% of the SGA-Bs and 60% of the severely malnourished were missed using a referral process. In other words, doctors and nurses or whoever else makes referrals to dietitians are not referring patients who need their dietitian's attention the most. Next slide, please. So we found out why do dietitians get consulted and what types of patients. So in the first 3 days of admission, generally the consults to a dietitian were for younger patients, patients with a metabolic diagnosis, anyone who had been taking oral nutrition supplements prior to admission, if they were put on a modified texture or renal diet on admission, and OR means odds ratio of greater than 5. So there's quite a high likelihood, 5 times likelihood, if they were on a modified texture renal diet, they would be referred. And an odds ratio of 1.88, or almost 2 times likely if they were severely malnourished. And that would not be because somebody had done SGA, but because people who are severely malnourished or appear wasted are pretty easy to identify. So some severely malnourished patients are referred. If the patient stayed longer than 4 days, the odds ratio for severely malnourished picked up at just over 2, and those patients were referred. If a patient had more than 2 diagnoses or a brand new diagnosis, more likely to be referred. If the patient looked like they were having dysphagia during the hospitalization, there was a very high odds ratio that they would be referred to a dietitian. If a patient was constipated or on antibiotics, they might be referred to a dietitian. We also followed patients post-discharge to find out what happened when they went home. And you can see that patients who lost more than 5 pounds after discharge were more likely to have a poor appetite upon discharge and be put on a special diet upon discharge. So people who gained weight were more likely to be younger, be male, be moderately malnourished and severely malnourished, are likely to gain weight. But going home with a poor appetite or on a special diet was not a good predictor for weight gain. So 16% said they gained weight and 26% reported they lost weight. This was another poster that we developed for Canadian Malnutrition Week based on that research data I just showed you. And this was done in 2017. So we're trying to raise awareness that there's got to be a sound nutrition care plan upon discharge, because patients will, if they don't go home with a good plan in place to make sure they eat and correct their nutritional status, then they're more likely to come right back into that hospital. So we found out 75% of malnourished patients do not see a dietitian in the hospital. Most leave the hospital in the same state as they entered. In fact, 1 out of 5 get worse. And we need to do a better job of connecting malnourished patients who are leaving the hospital with primary care and community services. So you can see in this poster that we use kind of the subway line approach, and the red line shows that patients who are likely to be at ongoing risk for malnutrition after discharge are what patients who are over the age of 65. They have a poor appetite, they require somebody to buy them groceries, and they're on a hard to follow diet. But people, to help them get home, we need to explain why food and nutrition are an important part of their recovery, confirm that somebody will monitor their appetite and weight when they're discharged. We need to encourage family to keep the shelves and the refrigerator stocked with food. Visit them at meal times, dine together. And we're constantly now encouraging hospitals, departments, not just the nutrition department, but to work with nurses, to work with occupational therapists, put together a contact sheet, helping patients in their community with various resources that could help them with access to food. And whether it means home care, outpatient dietitian, private practice, cooking classes, meal, grocery delivery, community dining programs, and provide a detailed summary of the patient's nutritional status to the family physician and other healthcare providers in the community so that they're aware of the problem and the severity of the problem. Next slide, please. So during our study, we also surveyed physicians to get their understanding of the problem of nutrition and we wanted to understand what they know about it. So we had 428 physicians collect data, and you can see that we asked questions about how important is it for them to be concerned about patients' weight at discharge, their weight during the hospital, weight on admission. NA stands for nutrition assessment at discharge, nutrition assessment during hospital, and nutrition assessment on admission. So you can see current practice is pretty low, but 77% agreed that using dietitian expertise more extensively would be helpful. The mean self-reported nutrition knowledge is 5.3 on a scale of 1 to 10. The mean interest in treating malnutrition was 6.9, and the mean relevance of being informed about how to treat malnutrition was 7.6. So basically, the physicians said that they don't know a lot about nutrition, but they actually would be more interested in being involved in treating it and being more informed about it. And there's just this comment over on the right-hand side that what we did find was community hospitals have a much poorer practice in terms of weighing patients. I don't think academic teaching hospitals are very good about it either, but it's our only one indicator other than visually estimating how much patients eat and knowing that patients are responding to nutrition care. Next slide, please. So we also interviewed or had nurses fill out this survey as well, and we got results from 346 nurses. And you can see that same types of questions that were asked. It was only modified slightly for nursing context, but it was the same survey that the physicians completed more or less. And nurses seemed to be a little bit more in tune to nutrition than the physicians. But 68% felt that dietitians or diet technicians should be responsible for nutrition screening. However, 91% did report that they could incorporate a 3-question nutrition screen into their daily work plan. The nurses' mean self-reported nutrition knowledge was 6.4 on a scale of 1 to 10. Their interest in treating it was 7.9, and the relevance of being informed on how to treat malnutrition was 8.4. So again, there's interest there. I think, well, there's some other issues. I think nurses generally think that they can't fit this in terms of their busy schedules, but those are issues that we've tried to address with our algorithm or nutrition care pathway, which I'll get to soon. Next slide, please. So in summary from our nutrition care in Canadian hospital study, we determined that, or learned that being malnourished at admission increases length of stay by 2 to 3 days. We found out that food access barriers are common in Canadian hospitals and potentially translate into poor intake during hospitalization. We did learn that eating 50% or less of the food that's provided is an independent risk factor for extended length of stay. So there are 2 risk factors for length of stay: being malnourished, and then while hospitalized, if patients eat 50% or less of the food, that will increase the length of stay. Hospital clinicians were not identifying malnourished patients, causing them to languish during hospitalization, and dietitians are not consulted to see malnourished patients. Next slide, please. So we needed to find a solution. So what we do know is that patients come in malnourished. So malnutrition occurs in the community. It's present in 1 of every 2 medical admissions. Current resources do need to be used differently. And malnutrition is perpetuated by hospital admission. So we are causing iatrogenic malnutrition because of some organizational barriers that get in the way of patients eating food. We need to work differently. Hospitals need to change their culture to embrace the importance of food and to treat food as an integral part of the patient's care. So it's not just about the tests and the exams and surgeries. Food is also part of the therapy. Food is medicine, medicine heals. And the entire team has a role to play. And partly because dietitians need to be considered as a specialist resource. They should be positioned to triage patients. We have for years, it's always been a concern for dietitians to care about how much or what patients are eating. But when you're not funded and staffed to be frontline staff, then you can't possibly see everybody. And we've known for years that dietitians have not been that effective alone to change the culture of nutrition care. So that's why we now have to focus on the entire team caring about it. And we do need to do a better job of connecting patients to the community services so that they have a very good nutrition discharge plan. And patients and family need to be involved in the monitoring and the care process. We think it's important that patients be told, along with their family, that the patient is malnourished and that might motivate them to maybe do something about it once they get discharged. Next slide, thank you. So what did we do? We developed an evidence-based pathway for the detection, treatment, and monitoring of malnutrition amongst medical and surgical patients. We developed this through consensus from leading Canadian experts, clinicians, and other stakeholders. And we consider this algorithm or pathway a minimum standard. And if a hospital or unit provides this care above this minimum, they're encouraged to continue their high-quality practice. This algorithm or pathway is called Integrated Nutrition Care Pathway for Acute Care, the acronym INPAC, and it can be found on our website at that link. Next slide, please. So this is what it looks like, and I've circled where it begins. INPAC starts with, you can see on the left-hand corner, it says admission, and it starts with nutrition screening. And we have tested and validated the Canadian Nutrition Screening Tool, CNST, and there are 2 quick questions that have to be asked. Have you lost weight in the past 6 months without trying to lose this weight? And have you been eating less than usual for more than a week? If the patients ask these 2 questions on admission and we get 2 yes answers, then it goes down to the next level of the pathway. Now, of course, not every patient can necessarily be asked these questions on admission because they might be comatose, they might have dementia, but to achieve a rate of about 70 to 75% of all admissions being asked this question will go a long way to determining the risk of malnourished patients. Next slide, please. So there are the 2 questions that I mentioned. Next slide, please. So the next, you can see I've circled subjective global assessment. So after screening, if a patient answers yes to both questions, they'll undergo subjective global assessment, and a trained clinician can get SGA done in 10 minutes. And the reason they're meant to undergo subjective global assessment is one can have false positives. So if a patient did answer yes to both questions, we do have to determine if they are in fact malnourished. And if they are not malnourished, they will move over to the yellow box under standard nutrition care. If they're mildly or moderately malnourished, then advanced nutrition care strategies would be put in place. And if they're severely malnourished, then it'll be an automatic referral to a dietitian for a comprehensive nutrition assessment and individualized nutrition care. I should say after screening, up at the top again, if a patient answers 1 yes and 1 no, or 2 no's, they're not considered to be at risk, and they would automatically go under what's referred to as standard nutrition care. Next slide, please. So here are the features of SGA that I did mention before. That's what our form looks like, and many dietitians across Canada have now been trained on how to do SGA. You might be working in a hospital where you've heard about it or seen it, or maybe you yourself have been trained, because I have trained some nurses as well. And completing that medical history on this front page, where you ask about the nutrient intake, weight loss, symptoms, functional capacity. You don't ask a patient about their metabolic requirement. That's just something you get from the medical chart. Anyway, that's what the form looks like. And some hospitals I know have incorporated that form right in their medical record, or they've taken variation of that form and put it in their medical record. Next slide, please. I wasn't sure if there was a page 2 on there. There's a second page. I forgot about that. There's a second page which lists all the physical exam features and what you look at and what part of the anatomy. So the temples, the under the eyes, the clavicle, the shoulders, triceps, back, scapula, quadriceps, and interosseous muscle, which is between the forefinger and the thumb. And that's where you look, and it gives you examples on the page 2 of what you should see if somebody showed evidence of wasting. And the other part was that we've actually now, we upgraded that form in 2017 to include elements of sarcopenia and cachexia. Sarcopenia and cachexia are not caused by malnutrition. Sarcopenia can relate to a low pro intake, but it's mainly related to aging and muscle changes. So exercise is the number one component for trying to slow down sarcopenia, as well as perhaps a little bit of extra protein. Cachexia, when a patient is cachectic, is, of course, you will feed them or treat them with aggressively, but cachexia is not eradicated by nutrition therapy, unfortunately. It's a process that the body goes through while it's fighting the disease. So this part, after they've undergone subjective global assessment, hopefully within the first 24 hours of admission, now on day 1+, they will, if they're well nourished, they will receive standard nutrition care. Next slide, please. So what is standard nutrition care? This is where the whole team matters. And the things that we can do, whether it's a nurse, a personal support worker, an occupational therapist, a physical therapist, a dietitian, but we need to make sure that patients are ready and sitting in their chair or positioned upright in bed. Do they need their glasses on? Do they need their dentures in to make sure they're ready to see the food and to eat the food? Do they need help opening food packages? Do they need help eating? And the important part is to monitor their food intake so that if we're doing a really good job of watching how much patients eat, and even if it's a visual estimation of 50% or less or 0% was eaten, it's recorded on your flow sheets, which nurses do, but sometimes I don't think people realize how important that information is. So the more accurate it is, the better. Because if a dietitian comes to check that they're not eating properly, then a more aggressive nutrition care should take place. We need to, if patients don't like the hospital food, is there something else we can do? Can we encourage family to bring food from the outside? Body weight does need to be taken at admission and weekly. And because as I mentioned before, it's really that and the visual estimation of the food intake are the only two objective ways of knowing that a patient is responding to the nutrition care plan. Next slide, please. The advanced nutrition care strategies encompasses what happens under standard nutrition care, but there are a few more additions to it. Next slide, please. So normally at this, we would recommend that a variety of other activities be taken to help improve the intake. Can we liberalize the diet? Get them off that restricted diet. Is it really necessary? Can we put them on a high protein, high calorie intake diet? Can they get ensure boosts between meals? Are food preferences taken so that we can give them the foods that they want? What we refer to many hospitals as MedPass, but can small amounts of oral nutrition supplements, such as 60 mils per medication round to help swallow the pills, be used in your hospital? If you give them 60 mils of a nutrient-dense oral nutrition supplement along with their pills, it's incredible how much the calories and the protein will increase throughout the day just by doing that simple step. And maybe we need to do a better job of investigating barriers that have developed with their patient's ability to eat. So do they require an eating assistance? Does the patient have dysphagia? Are they depressed? Are they in pain? Because some of those problems can be easily corrected. Maybe they need a painkiller. Maybe they need some emotional support. I encourage dietitians when I go across the country, when I do the SGA training, is to be better sleuths. Find out why patients aren't eating. There are a multitude of reasons. Next slide, please. So the last part of this pathway, or almost the last part, is the comprehensive nutrition assessment. That would be, as I said before, the automatic referral to the dietitian. Next slide, please. And here, the dietitian would do a comprehensive, they've been determined by SGA that they're severely malnourished. The dietitian will do a physical exam. She will use anthropometric measurements, perhaps other anthropometric measurements such as a hand grip strength, food intake, history, clinical and biochemical markers that might be specific to that condition and the patient population, and to determine how they're swallowing and their eating capacity. Determine if there are any additional barriers identified on that unit, and collaborate with the patient, family, and the healthcare team to make sure this patient gets as much food as possible. And if nutrition support is required, in this case, I'm referring to parenteral or enteral nutrition, then they should be referred early, and that patient needs to be treated aggressively. And then the last exceptionally important piece of this is sound nutrition care plan for discharge. Can't say it enough, because what we really want to do is prevent patients from being readmitted. And while our study didn't show this, we have seen other jurisdictions' data from the United States and Europe where malnourished patients are more have a high rate of return to hospital if they're not eating properly upon discharge. Next slide, please. And the nutrition discharge plan includes education prior to discharge, watch for symptoms such as poor appetite and weight loss. This is a repeat of that slide I showed you, but look, list of community resources, provide them with information about oral nutrition supplements, where and what to buy, and a referral to relevant care providers, and definitely inform the family physician. Next slide, please. So this is a summary, and this is where it includes the nurses. All hospital staff play a role in nutrition care. So we need to create an interdisciplinary site team to change nutrition care practices in your hospital. It's not going to work unless you can get a nurse manager, some staff nurses, the VP of nursing, physicians, and other relevant healthcare professionals, the food service department on the site team to help start changing nutrition care. And it really does have to start with nutrition screening, because otherwise we will not know how to identify the patients. But the key question here is who will do it. Remembering that dietitians are specialist resources and they can't see every patient unless they're resourced to do so. So it is recommended often that nurses ask the 2 questions upon admission. Some hospitals have somehow got the funding to have a diet clerk ask the questions. It doesn't matter who does it, but it does need to be done. And there has to be a trigger so that anyone answering those 2 yes questions will have a dietitian see them to do SGA. And the next step would be to train appropriate staff to do SGA to determine if at-risk patients are in fact malnourished. Who will do it? Dietitians, physicians, nurses, diet technicians. It doesn't matter who does it, but again, the system needs to be established as to who will do it. Provide excellent quality food that meets the patient's nutrient requirements for a myriad of health conditions. Be food aware and treat food as a vital component of patient care. Treat hospital food with respect. Try it. You might like it. This past Canadian Malnutrition Week, we always host Canadian Malnutrition Week the last week of September. And the theme this year was to try it. You might like it. We got food service departments to have hospital staff try the food. And the response we got back from it was actually quite remarkable. That when they had nurses, doctors, other healthcare professionals try the food, the response generally came back overwhelmingly positive in that, oh, this is better than I thought. And then some hospitals said that when they got poor results, now they're going to go back to the drawing board and improve the recipe for those food items. So rather than turn your nose up at the food and tell patients, because it tends to be such a bad joke about, isn't hospital food terrible? Before you comment on it, try it. We need to implement strategies and procedures that address organizational behavior barriers, the effects of illness, as well as the barriers that affect patients' ability to eat. We do have a mealtime audit form on our website that people can fill out usually it's a dietitian or somebody from food services will fill it out. And what it is the audit looks at how the whole unit is ready for food, for patients to receive food, and where they can improve. Provide alternate sources of nutrition, enteral-parenteral if the food intake's not ideal, and start early in the admission. And provide a nutrition care plan for malnourished patients, and let's ensure excellent quality care after discharge and prevent readmission. And the nurses are instrumental in helping the dietitians with this, if nothing else, to at least identify to the dietitians, so-and-so is going to be discharged in the next day or so. Next slide, please. So food is medicine, and medicine heals. That's the end of my slide deck, I believe. Next, is there another slide?
That's the end of the presentation. And thank you, Bridget, for this presentation. It's quite interesting to hear the results of the study and some of the interesting actions that you have raised that will help prevent this from happening in Canadian hospitals. We do have some questions that we have received in advance, and really want to hear from Bridget's experience. What are some Canadian hospitals doing about this issue, and can you potentially give us some common practice or some ways that some hospitals have integrated these ways of assessing and doing some proper consultation with dietitians?
That's a good question. Thank you. So what I didn't mention in this presentation is Heather Keller is a professor of nutrition and aging at the University of Waterloo. She was the co-chair of the Canadian Malnutrition Task Force for 8 years, and she recently stepped down as co-chair or chair and co-chair, and now she is still a member of CMTF, but she did get funding from the Canadian Frailty Network at a Queen's University. And what we did was we took INPAC and implemented it in 5 hospitals in Canada. And it was for a whole calendar year from all of 2016. And each hospital of the 5 hospitals, one was in Edmonton, Regina, Winnipeg, Niagara Falls, and Ottawa. And what they did was they all implemented nutrition risk screening, and they all implemented SGA. And then each hospital from there worked on different areas. So one of the hospitals in Regina focused very much on standard care, and they took photographs. They got all of the food, different scenarios of how much food was eaten or not eaten. They trained the food service workers and the nurses on how to identify quantity of food. And then what happened was they did some time and motion studies and found out that, yes, it did increase the length of time for the food service workers to go and pick up the trays, and actually recorded the amount consumed on the patient's whiteboard for all 3 meals in a day. But in case it didn't happen, the nurses were also trained to how to analyze that. And then they would put it on the whiteboard, and at the end of the day, the nurses would transcribe the results in the patient chart. It took, it was a lot of training and a lot of time involved, but the end result is they feel that they've got really good standard care available at that hospital in Regina. The other thing that they did is when they developed their site implementation team, was they talked about the importance of weighing patients. And so they asked the nurses, how can we get this to be done on a regular basis? And so it's consistently done, because, you could get a physical therapist to weigh a patient occasionally, or a dietitian, but how can we consistently get it done? The nurses said they would be happy to do it, but they asked for Saturdays, because Saturday was a better day of the week. They seemed to have more time. So by including the nurses in the decision-making, they came up with a plan. And patients are admitted on a wait on admission and wait every Saturday. And when they have their huddles, they actually always report now how much food the patient does eat at each meal. So it's become, in Regina, at Pasco Hospital, they feel that they've got really good handle on standard nutrition care. Another hospital in Niagara Falls put together a really good volunteer program where they've their volunteer coordinator was really excited about this, and she went and developed a program and trained volunteers to go, and they don't feed patients, but they actually go and visit the patients and encourage them to eat, make sure that their packages are open. And it's kind of like a cheerleading role, and that they encourage them to eat the protein that's on the food, on the tray. So that's one thing they did. And another hospital in Edmonton decided, they heard from the nurses that it's really important to have food available on the nursing unit. So they actually got fridges back in, and appropriate foods to give patients when they've missed a meal or they're hungry. And again, that's working well. But when you do a lot of awareness raising and a lot of education to the nurses, to the doctors, to everyone else, I think what's happening is that nobody's stealing the food now anymore. And so there's not the concern that the patients won't get the food. So there's been some of those culture changes, but what's the key to all this is the site implementation team does need to have nursing leadership as well as staff nurses to help problem solve, because the dietitians maybe can identify what some of the problems are, but they certainly don't have all the solutions. And it's hard to ask another profession to do something when they don't have the buy-in or the interest. But as long as they understand why they're doing it, and that they know that their work is valued. So if a nurse is recording those 2 simple nutrition screening questions at the beginning of the day or of admission, and they know that data is being used, then they reported to us when we were going from site to site during that 1-year implementation study, is they're happy to do the work as long as it's valued. Thank you, Bridget.
We did receive another comment about the quality of the food in some hospitals, and that's a concern by this participant, is that many foods are processed, and fruit and vegetables often come from a can, and it's really challenging, and the challenge is to have fresh food and local food come to hospitals, and it seems like it's questioning some of the food that is served in hospitals. So that's an ongoing challenge that you have brought solutions to some way bring some foods from home or as the family, but that's sometimes that's not always possible.
Right, I agree. But here's the good news. The Canadian Malnutrition Task Force, I mentioned this at the very beginning, has formed a food and healthcare working group as a result of the fact that 25% of our patients said they didn't like the food, but we felt it's time to address the actual food issue. So the this CMTF Food and Healthcare Working Group has been meeting since January, once a month, and it is comprised of mainly food service directors from across Canada who work in hospitals, and their goal is to develop standards for hospital food, particularly in mind of preventing or treating malnutrition. So they just finished a large data collection survey over the summer, and they're just analyzing the results. And then we're going to start the process of now putting together some draft, we're going to refer to them as fairly prescriptive standards, and we need to test them. But that should be coming out in the near future, and sometime in 2019. Because believe it or not, there are no standards for hospital food. So that's what hospital food service directors used to do, was use Canada's Food Guide as a basis for menu planning. Well, Canada's Food Guide is actually a guide for healthy populations. It's not a menu planning. It was never meant as a menu planning guide for unhealthy populations. So we're trying to encourage, with our new standards, we'll get away from using Canada's Food Guide as the basis for menu planning. The other thing that you probably aren't aware of, there's a group that formed almost 2 years ago. They're called Nourish. And if you Googled Nourish Healthcare, you'll see their website. They are funded by the McConnell Foundation out of Montreal. And their mandate is to try to work with hospitals to get local, sustainable foods, fresh foods, high quality, nutritious foods in hospitals. So they're aware of us, we're aware of them, we've co-presented. So between perhaps some of the work that Nourish is doing and some of the work that we're doing, perhaps you might start to see some changes, because we think that there should be more pressure on hospital CEOs to not cut the budget for food services and to make it an integral part of nutrition of the patient's therapy.
Thank you, Bridget. I have one last question about more of the screening that you described. How long does it take to complete the screening tool?
2 minutes or less.
Okay.
So what's happened is, so these 5 hospitals that implemented INPAC, again, everyone always is concerned when it first starts, oh my goodness, that's going to increase my workload, whether it's a nurse or a dietitian, because even the dietitians were saying, oh my goodness, we're going to get all of these referrals to do SGA. I think what happens is once you settle into a new routine and you figure out the whole processes, it doesn't actually, it nets out zero. It's, for example, those 2 questions are not that different from what's asked about nutrition in the Braden scale. But one complaint I heard when I went across the country doing focus groups is nurses would say, we always have to fill out the Braden scale, but I don't think anyone pays attention to it. So now we are saying, just if you can ask these 2 questions, and the difference will be is somebody actually will pay attention if there's a good referral system set in. So because nurses have to ask so many questions of patients upon admission, we're just asking and encouraging, could you ask these 2 more? And if the answer is no, then perhaps the nurses could actually help the dietitians or the whole team figure out who can do it, who can ask these questions on a consistent basis, and let's support that person in that role.
Thank you, Bridget. That's all the time we had for questions and answers, and we really appreciate having Bridget to explain what's in place and give a bit more information to nurses, and this is really valuable information. And now we are asking you to answer some polling questions, and you'll see them on your screen. Okay. Well, now that's the end of the presentation, and we have on the slide Bridget's information and email. If you have any more questions and need more information about this topic, we invite you to write to Bridget, and the webinar will be available on the YouTube channel as you see on the slide. And we encourage you to look for the next webinars early in January. We'll be posting some new topics, and we really appreciate your participation. Thank you, and have a good day.